Well, hello and welcome to all of our viewers around the world. I'm Fiona Langsharp, IBCLC Director of Communications and MC here at Gold Learning. Well, we're back talking about our Gold Neonatal Online Conference 2024. If you can believe that, it's right around the corner. And we've got some fabulous topics coming up, including this one, our evolving knowledge of drug metabolism in the neonates. So thank you so much to, of course, Jim Thigpen, who is here with us today. Jim, of course, you're not new to Gold, have been with us here before, and so it is lovely to have you back here at Gold.
Thanks. It's great to be asked back, and it's great to be here talking to you guys today.
Yeah, absolutely. So this topic, wow, you just gave me a little bit of food for thought, as we were talking about it coming up, and just understanding that the limitations that we're still in when it comes to how drugs really behave in neonates and some of the ongoing things that we're really trying to balance. So why don't you start us off just by telling me a little bit about what you have discovered? I mean, you've been doing this for some time, but what got you really excited about this particular topic?
Well, honestly, I've been a pediatric clinical pharmacist for over 30, oh my gosh, 34 years now. And I've seen medications evolve over the years from what I thought were old drugs in the 1980s when I started doing all this to the same medications we still use.
Mm,
And I thought that, 20, 25 years ago, we'd learned everything we could ever learn about gentamicin or vancomycin or indomethacin. And yet we're still continuing to learn, and the babies keep getting smaller. And there's just so much that we don't know, and we don't know how their livers are acting. We don't know how their kidneys are acting. We don't know how their own genetic makeup influences how they metabolize these medications. And I'm thinking, this is a good opportunity to educate myself a little bit more about all these things too. Um, and it's a daily thing, and it changes from week to week with these babies, and we're always searching for more information about how to do things the best way and how to minimize any kind of side effects that these medications have and still try to do the best we can to help these babies get better. And it's just a continual challenge. And the more I've read, the more I've learned, the more I realize that we still don't know very much, that we're still learning about these medications 40 years after we started using them. And but the future is becoming a little more clear. And I think what we will be doing 5, 10 years from now is going to be remarkably different than what we are currently doing. And we're going to be so much more um, specific about certain medications with certain babies. And
mm.
in this baby, we will use this medication when, and this one we won't, based on their own genetic makeup and information we can gather. And so it's an exciting topic, but it's still, again, there's so much more that we don't know. And I think the listener will learn that, well, yeah, that guy told me a lot I didn't understand, but he surely doesn't know what the answers are yet. And I'm going to say, you're right. That's exactly what you should come away from with this presentation. So
Yeah, this is really something that is ongoing. And as you said, you anticipate that there's going to be a bigger movement per se in this area than you've probably ever seen. And is that because of the research? Tell me what's happening in research right now, because as I understand it, there's very little research really done on, preterm infants when it comes to drugs and such. So tell me a little bit about what you've seen happening in the field.
So it is very difficult to do research, and that's one of the things we'll talk about in this population, because I mean, it's just they're very, very sick, and you're trying to figure out a way to get information from their blood samples and from various tissue samples and trying to study them. And you've got very nervous, very scared parents who are afraid
Mm,
to allow their child to be a part of a study. And rightly so. I would be too. And then we're limited as to the technology that we have as to how much blood we need to do this test. And I
right.
think as we move forward, we're going to get better at that, and it will require less and less blood to do the sample or to do the study. so therefore we'll be able to learn more with a limited amount of information from that baby compared to what we have historically had to do. And so that in itself, I think, will open up a lot of doors to what we're trying to learn, and then will allow us to take the next step with, well, if this is happening with this patient, then this medication might be a better option over this medication. And again, I think it's going to be the population isn't going to, it's not like the population is going to change. They may get
Right.
slightly smaller, but I think the technology will change to the point where we can gather this information more effectively and more reliably with smaller volumes, and the technology will help us gain the information that we need, that we currently can't, or we currently are limited as to what we can gather. And then, of course, we're going to learn more and more and more in older children and adults that we can hopefully apply.
Apply it.
But
Yeah.
again, this population is different. They're not just little adults, and they're certainly not just little infants either. They're a
Hmm.
completely different category. I tell my students that you have adult medicine, you have adolescent medicine, you have pediatric medicine, and you have neonatology, and they're all different. And then now, the more I learn, you have premature babies that are different than just neonate. I mean, it's just complicated. And I'm sorry, I'm rambling a little bit, but that's kind of, it's overwhelming to think about. But I do think, getting back to your question, I think the technology will get better, where we can gain this information from these babies and make some more informed decisions in the future than we can now. So
Yeah. And I think that's what I feel, that's where, neonatology is really moving. We're talking a lot about developmental issues, outcomes, long-term outcomes now, and really wanting to mitigate these concerns. And of course, medications play a role there. I have another question for you in regards to genetics and how that role has changed things over the last few years, in terms of drugs and medications. What type of influence does it have now, in what we're doing as far as pharmacology goes?
well, it can have a tremendous influence. If I can just use an example for adults, and certain psychiatric disorders that patients will have, um, we will give them a medication and see if it works. And if it works, great. If it doesn't work, we'll try something different. Oh, and if that doesn't work, we'll try something different. And you've got time that is being spent trying to figure out the best medication for this patient. But now you can do a genetic profile of that patient, learn which drugs they metabolize best, or don't metabolize at all,
Hmm.
and you'll give them a medication that their system doesn't metabolize it. It's never going to work. Doesn't matter what you
Right.
do. And so it's going to speed up the time involved in far less trial and error. It will be like, well, you shouldn't get this one and this one. We should give you this one. And
Mm.
so that genetic makeup, that drug metabolizing capacity that patients have, will learn earlier. And so we will therefore pick not these medications to try and fail. We will know more exactly which medication we should give them and what we think is going to work. And also, in some respects, know exactly what dose is most likely to be effective.
Mm.
And so there'll be far less trial and error. And that will be helpful. In neonatology, there's some limitations there, because some of the things we just can't study the way we can in adults. But for
Right.
example, for like epilepsy, if you have a baby and they don't metabolize levetiracetam Keppra the same way other babies might, then you may not want to use that, or you may want to start with a higher dose. And so it'll help drive it, and we'll have less trial and error with some medications. We'll know more specifically about which ones to use based on how they metabolize medications. But the other thing about this is that, well, at 28 weeks, they metabolize it this way, but at 34 weeks, they metabolize it differently. And so I'll use the term moving target. It is a moving
Right.
target. And
Yeah.
so neonatologists, nurse practitioners, pharmacologists, we have to pay real close attention to all the little nuances. And you've got a baby that's growing and sick and premature, and all these things are moving at the same time, and you're trying to give them the right medication dose. Number one, the right medication. Number two, the right medication dose and the right medication interval. And it's a moving target, but it's fascinating. It's terrifying at the same time, and it's challenging and rewarding. And so uh, what else is there to say? That's the world we live in. So
Yeah. Well, I think you said it very clearly, that moving target that, that drives you in your work to make sure that, you continuing to stay up to date. And bringing this presentation really, I think, is just so enlightening to understand where we're at today and what we do know and where potentially we could be in just a few years is just astonishing. So, we can take that as a win for sure. There's a lot of things that stand still for a long time, but it seems like we are heading in the right direction. So thank you so much once again, for being part of this conference this year. You can head over, for all of our viewers listening right now, you can head over to the website at goldneonatal.com and register today. That's the exciting news. We will be opening up really soon with our opening keynote, so you can check out all the dates. You can come and join Jim and myself live on the day as well, so you can check out when he's going to be live. All the presentations, of course, are recorded, so you can listen to them either again or at your convenience. It's a great way for you to get all of your education. Thank you so much to Jim Thigpen for being with me here today. It's been lovely having you.
always good to join you, Fiona.
And to all of our viewers, don't forget again to check it out at goldneonatal.com. We'll look forward to seeing you all online. Bye-bye for now, everyone.